G6PD deficiency. And this, what happens is you have NADPH. As I just told you yesterday, we were discussing about this, that your NADPH is basically it reduces your glutathione, and reduced form is very, you can say, good to the cell. If you have this whole thing in oxidized form, it is very toxic to your RBCs. So that's the main thing, that whenever you have triggers, stressors, what they do is they utilize your NADPH because it works as antioxidant. And if it is consumed or utilized somewhere else, what happens is you cannot detoxify your free radicals and peroxidize. Okay, and in a nutshell, you damage your RBCs and it leads to your hemolytic anemias and all this stuff. The main thing, the main question that are focused for the step one in this disorder is what are your triggers. Okay, so remember fava beans, remember sulfonamides, nitrofurantoin, primaquine. These are ones that are always tested, especially sulfonamides, nitrofurantoin, and primaquine. Infection, you have to always keep in mind any kind of infection can precipitate your G6PD, and yeah, these are the ones. This is X-linked recessive disorder. It means it is most commonly seen in males. Okay, and what kind of population is affected? Your Southeast Asia or Africans. This can sometimes help you, but generally it's very obvious when you know when it comes shows up on your question. They can literally ask you or mention or give you the slide of histopathology in which they can ask about what are these. So these are your Heinz bodies, which are basically what happens that your this is your RBC. Okay, this is composed of hemoglobin. So your globin chains, basically they precipitate in response to this oxidative damage, they precipitate, okay? And this leads to precipitation of these hemoglobin bodies, and on histopathology, you can see these Heinz bodies. You must have seen some UL question in which they have given you good pictures. Remember them, keep them in mind. Sometimes they just give you the histology in the question, okay? Bite cells are simply your damaged RBC. You can say this RBC is basically, you can say, damaged, and when it goes to the spleen eats the damaged area, and because of this, the RBC takes a shape of a crescent or something like this. Okay, these bite cells can also be seen. So if we on slide you see bite cells along with these Heinz bodies, these are basically precipitation. You will see some kind of dots or something. If you see this thing happening, it's your G6PD deficiency. The main focus you should have for your exam purpose is on the histopath and on the triggers. Okay. Now we will talk about fructose and galactose metabolism. They are very high yield. There is always one or two question on this in your practice exam, in your UL, and all these things. So first, you need to keep in mind that essential fructosuria or hereditary fructose intolerance. These are two types of your fructose metabolism diseases. The first one, whenever you will have kinase deficiency, okay, it will be a benign disease, whether it's fructose or whether it's galactose. Okay, this thing you should keep in mind. Whenever you have kinase deficiency, you will see that your disease is benign. So kinase is kinder. This thing you have to keep in mind. Okay, and in this disorder, what happens is you do not have fructose kinase, and if you do not have fructose kinase, what happens is you cannot take in the fructose and cannot convert it into fructose 1 phosphate, and if you cannot convert it to 1,6 phosphate, it cannot contribute to glycolysis. Okay, so whether it's fructose or whether it's galactose, they both like to contribute to glycolysis pathway. Okay, that's the main thing that you should keep in mind. And if you do not have fructokinase, as I told you, what will happen is your hexokinase will try to convert this fructose into fructose 1 phosphate. So like this pathway is mediated by two enzymes, fructokinase, hexokinase. You prefer that fructokinase should do it, but if fructokinase is absent or you have a deficiency, it could be done by your hexokinase too. Okay, so that's why it's a benign disease. You do not accumulate your fructose. That's the main thing. Fructose is not trapped into cell. As I just told you, hexokinase is there, it converts it. This is autosomal recessive. Then your fructose 1 phosphate is converted into this glyceraldehyde or DHAP. And if you remember from glycolysis pathway, they both can contribute to your glycolysis, form your pyruvate, and from that you can make acetyl CoA. Okay. So the whole idea here is that if you have deficiency of this, there is no alternative enzyme that can convert your fructose 1 phosphate to your DHAP or this glyceraldehyde, which can contribute to glycolysis. So this means that you will accumulate fructose 1 phosphate. And if you keep on accumulating fructose 1 phosphate, which literally means you capture the fructose and attach a phosphate to it and convert it into fructose 1 phosphate, right? It means you will utilize all the ATP sources. Okay, if you utilize all the ATP sources, your phosphate will go down, and this will tell you, or this will inhibit the whole gluconeogenesis or glycogenolysis pathway. Why? Because you need some kind of phosphate to be available for these pathways for some reason. Okay, if you do not have it, you will inhibit this. So main thing, you have fructose. If you have aldolase B deficiency, it means you cannot convert your fructose into DHAP or glyceraldehyde. If you accumulate your fructose 1 phosphate and your body stores of fructose are very high, your fructose will be, it will be keep like it will keep growing, and it will be converted to your fructose 1 phosphate and utilize all your phosphate stores and inhibit your glycogenolysis and gluconeogenesis. And that's why it means if you inhibit this, it means you can develop hypoglycemia. And of course, if you keep on accumulating this component, ultimately it's not contributing to glycolysis because this enzyme is deficient, right? So you will develop hypoglycemia. You can develop jaundice because you're accumulating a toxic, you can say, component in your liver cells. It can lead to cirrhosis, vomiting, all this. And sources are very important to keep in mind. In questions, they always try to mention what kind of source, like what the children ate or something. It is always there to give you hints that what kind of deficiency you're dealing with. So you can remember it. Fruit juice and honey are main sources of your fructose. Okay. And how do you treat for benign disease? You do not need treatment, but for your, of course, for your fructose intolerance, you need to decrease eating these fruits, juices, and honey. So decrease intake of fructose, sucrose, and sorbitol, because sorbitol is ultimately metabolized to fructose. We will come and talk about sorbitol in detail afterwards. Okay. The other thing that you should keep in mind that you do two type of test. Okay, to detect these sugars in your urine. First is urine dipstick test. Okay, that can only detect glucose. That can never detect galactose or fructose. That if your urine dipstick is positive, it means that you are having glucosuria. If your urine dipstick is negative, it means it could be either fructose or galactose. Okay, and you see, if you see reducing sugar, again it's very non-specific because reducing sugar literally means it can be glucose, fructose, or galactose. It could be anything. So again, non-specific test for detection of carbohydrate metabolism. So these tests you should keep in mind. They will always mention this in question. After this, we have galactose metabolism. For galactose metabolism, you should keep in mind that again, if your kinase is deficient, it's a benign disease because it's a kind of disease. One thing here you have to note that galactose is basically converted into galactose 1 phosphate by the enzyme galactokinase, and of course it's deficient. It does not lead to problem. Why? Because this galactose is again then converted into galactylol, and whatever ends with T-lol, you have to remember it can lead to cataract. Okay, whatever ends with T-lol, it can lead to cataract. So this galactose is basically converted into galactose 1 phosphate by galactokinase. If this enzyme is deficient, you do not see any kind of other symptoms except for cataract formation. Why? Because your galactose is the one that is converted into galactylol, because this pathway is shut down. So the only way this galactose can be metabolized into something is by galactylol. Okay, this thing you have to keep in mind. Another thing is that galactose can appear in your blood, so galactosemia would be there, galactoseuria can be there, but no symptoms, no hypoglycemia, nothing like this, only infantile cataracts because of this T-lol thing. Okay, may present as failure to track objects or develop social smile because your eyes are affected. So of course you did not visualize any kind of object, and you do not know, like your vision is impaired. So how can you be like children? They communicate only by smile and facial expression, all this stuff. So they failed to do that thing. Classic galactosemia is like converting your galactose 1 phosphate into glucose 1 phosphate by enzyme galactose 1 phosphate uridyl transferase. Okay, If you are deficient in this uridyl transferase, again you cannot contribute to your glycolysis or glycogenesis, like you cannot contribute to anything. And this means what will happen, you will accumulate galactose 1 phosphate, and this galactose 1 phosphate will be accumulated and converted back again into galactylol, and it will again lead to infantile cataracts because of this T-lol deposition, as I just told you. Okay. And you see other symptoms as well, like failure to thrive, jaundice, hepatomegaly. Intellectual disability is something very important you should keep in mind. And the other thing that they like to go after is E. coli sepsis. They can ask you, like, these patients, these children are at risk of what kind of infection. It's your E. coli. Okay. And what happens is, what is your source here for galactose? It's your breast milk or your fed formula. Okay, both of them. You avoid the diet, exclude the diet that contains galactose or lactose. Okay, that's the main idea. Now we have sorbitol. The thing you can remember, that your cells are basically, you can say, greedy for glucose. They want to trap more and more glucose. Like insulin helps you to pick up the glucose inside the cell, right? But there is another way that you can pick up the glucose. It's by aldolase reductase. Like this enzyme, what it does, it picks up glucose and stores it inside the cell. Okay, so cells are basically greedy here, and this glucose is converted into sorbitol and sorbitol into fructose. That's what we just studied here. That you need to avoid sorbitol as well, because your sorbitol can contribute to fructose too. Okay, this is something that you should keep in mind. And then the other point here is that if you have deficiency, like, yeah, so okay, so what will happen, you will see problems with sorbitol only when your glucose level are so high. Okay, it means your glucose will keep on accumulating inside your cells, and those cells either are deficient in this enzyme or in this enzyme, right? And like only those cells that are deficient in this enzyme or this enzyme, only they are affected. No any other cell of your body is affected. Okay, so whenever you have excessive glucose, your cells think, okay, I should pick it up and take it inside me. And what happens is that they become greedy and they pick the glucose, but they are deficient in this enzyme, aldolase reductase or sorbitol dehydrogenase. Like, we will talk about what kind of cells they are, and that's why they are toxic to the body. Some tissues then convert. I told you this whole thing. Yeah, so you should remember your liver, ovaries and seminal vesicles, they have both enzymes. It means they can use your glucose and convert it into fructose, and ultimately this goes into your glycolysis pathway. Okay, it's your lens that only has aldose reductase but does not have sorbitol dehydrogenase. It means your lens will accumulate sorbitol, and I told you whatever ends with like T-lol leads to cataracts. That's why in chronic hyperglycemia, why do you see cataracts in eyes? Because of sorbitol deposition. Why? Because your glucose was converted into sorbitol. Because your lens just has this aldose reductase, but not sorbitol dehydrogenase. Okay, and your retina, kidneys and Schwann cells only have this enzyme. Again, they will accumulate this sorbitol because they do not have sorbitol dehydrogenase. That's why if you remember, you see retinopathy, nephropathy, peripheral neuropathy in your diabetes. Why? Because these cells accumulate sorbitol, which is toxic to your cells. Okay, this you have to keep in mind. So what, like, these are the cells that are affected by sorbitol metabolism. And why are they susceptible to this? Either they only have this enzyme and they miss this enzyme. Okay, your other cells of the body, they have both things, like both these enzymes, so they metabolize this whole thing to fructose, and this ultimately goes into your glycolysis pathway. And what else I should tell you? Yeah, I've told you everything. Okay, then you have lactase deficiency. For lactase deficiency, this is something very common, and like very commonly also tested, so you should know this. It's like whenever you have lactase enzyme is present on the GI tract, on the brush border of your GI tract. Okay, and whenever you do not have this enzyme lactase, you can develop lactose intolerance, which means your your lactose will come in, inside your GI tract, and it will be, you can say, like normally it's metabolized to glucose and galactose. Now, since you do not have this enzyme, okay, what happens is your bacteria ferment this, and if your bacteria ferment this lactose, it can lead to hydrogen production, and that's how your one of your test, that is your hydrogen breath test, can help you detect it. Okay, why would you develop lactase deficiency? It's either because you have primary deficiency or secondary deficiency. This could be important because they can just tell you that the person is suffering from lactase deficiency by giving you this whole scenario that the person presents with, you can say, diarrhea, bloating, flatulence, and all this stuff, and they can ask you why is this happening. So it could be either primary, which means like when you grow up, you generally lose this lactase enzyme with time. Okay, or you did not have enzyme in the first place, like from childhood. So this is also common in Asian, African, American descent. Sometimes ethnicity is mentioned, so it can also help you. Secondary common, like secondary causes can be very common and they can be tested. It's why because they will give you a scenario: someone suffered from upper respiratory tract infection or GI infection, or some kind of infection would be there, and they can ask you, now this person is suffering from lactase deficiency. Why is this happening? It's because of your previous history of gastroenteritis, upper respiratory tract infection. It could be anything. So this whole thing can lead to, again, lactase deficiency. This could be tested. Other is your autoimmune diseases. You can just keep this in mind. And uh, I told you how would you detect it, because your lactase that is not metabolized into glucose and galactose in your gut. So your bacteria, what they do is they metabolize this lactose into some kind of, you can say, they ferment it and they produce your hydrogen. And this hydrogen can be detected on hydrogen breath test. Okay, and you can see that your stool pH is decreased, like it's very acidic, because you're producing more and more hydrogen from the fermentation of your lactose. And who does that whole thing? Your bacteria, colonic bacteria. That's the main thing. To confirm your diagnosis, or maybe they mention in the question or whatever, mostly lactase deficiency is clinical diagnosis. You never jump to your biopsy results. Okay, but for step one, they can just mention that we did they can mention in the question that we did a biopsy, it was normal, and there was nothing there. So it confirms you that this is your lactase deficiency. How do you treat it? You treat it by avoiding the lactase. I mean dairy products and all this, and you can also supplement your enzyme like the lactase itself. It can also help you. I told you about the symptoms as well. So this is all about it. And these amino acids, essential, acidic, basic, I will not go through them because they are not important like this. The main things I'll tell you. Urea cycle, we will cover it with your pyrimidine synthesis, because that's very linked to it, so it will make more sense to you guys. So I'll cover it with your pyrimidine synthesis. This can be important, amino acid derivatives. We will talk about this process in detail, like this thing. You should always remember your tryptophan is making your niacin and your serotonin. Okay, this you have to remember. This is very important. And if you have you can say your tryptophan basically makes your niacin and serotonin. So if someone is suffering from serotonin tumor, like a serotonin syndrome or something like this, right, like you can say carcinoid tumor, right, you utilize all your tryptophan into the formation of your serotonin, and that's why you can develop your niacin deficiency. So this is something that you should keep in mind, that whenever you have carcinoid syndrome or something, you are prone to develop B3 deficiency. Why? Because your tryptophan is the one that synthesizes your niacin. Okay, and then you have your cofactors B2 and B6 that help with the formation of your niacin. This you have to keep in mind. You can remember niacin is B3, so your B2 and B6. Okay, so it gives you the number 3. In this way, you can remember it. And for serotonin, it utilizes BH4 and B6. Cofactors you have to remember. They like to ask this thing. Okay, and now the serotonin is either converted into melatonin, or niacin is either converted into NADP plus or NADP. Histidine is converted into histamine by B6. This you have to again keep in mind. Glycine is converted into porphyrin and heme. This you will understand better if you are done with hematology, that glycine is basically the one that contributes to the heme synthesis and utilizes B6. For most reactions, it's B6. You can keep this in mind. For transamination, for synthesis of some neurotransmitters or all these, it's always the B6. We will cover vitamins, they are very important, and I'll make it more clear to you guys. But now you can just keep this in mind that B6 is there for internal reactions, it's always B6. Glutamate again can be converted into GABA or glutathione by using your B6. Arginine can be important in terms of nitric oxide. Okay, they can talk about it. uh, when we discuss about urea cycle, we will talk about how arginine helps with the urea cycle, but these two you should always keep in mind, and this part we will come into it. Okay, phenylalanine is converted into your epinephrine and your norepinephrine. This whole pathway is very important, their cofactor, their enzyme names, and all this. Okay, so you should remember that whenever we will deal with your hydroxylase enzyme, like the first two, this is for your memorization purposes. First two hydroxylases enzyme, what will you use as a cofactor? BH4. This you have to just keep in mind. This is very important. And when we convert dopamine into norepinephrine, we again use a hydroxylase, but that is beta hydroxylase. Okay, and whenever we use beta hydroxylase, we use vitamin C. So you can remember B comes after C. So beta hydroxylase, like dopamine beta hydroxylase, it utilizes your vitamin C and converts your dopamine into norepinephrine. Okay, and yeah, so phenylalanine is converted into your tyrosine. Okay, by utilizing BH4. And what is the enzyme? Phenylalanine hydroxylase. So if you do not have a cofactor, or if you are deficient in this enzyme, you can see phenylketonuria, which we will discuss ahead. Then this tyrosine is converted basically into L-dopa by your tyrosine hydroxylase. Okay, and this tyrosine hydroxylase is also converted into your homogentisic acid. This homogentisic acid is basically toxic to your body if you cannot metabolize it to other components like melanyl acetoacetate, and this can go into TC cycle in the form of fumarate. Do you need to remember this whole thing? No, you should just need to remember this, that tyrosine can be converted into dopamine and it can be converted into homogentisic acid, and we have to metabolize this homogentisic acid. If we do not metabolize it, it leads to a disorder which is known as alkaptonuria. We will talk about it. And after this, you need to keep in mind that your L-dopa is converted into melanin, and it is also converted into dopamine. And here, what kind of enzyme plays a role? Dopa decarboxylase. This is very, you can say, famous, or you might guys know this drug. I mean this enzyme name, and that's why there is a drug that acts on this enzyme, which is your carbidopa. Okay, so why do we supplement this drug? Because you might guys know this, that it is because your carbidopa basically decreases the peripheral conversion of your L-dopa to dopamine, so that your dopamine can go into the CNS and help with your Parkinson disorder. Okay, so that it's not metabolized, all of it is not metabolized peripherally, right? That's the purpose. Anyway, so this dopamine is then converted into norepinephrine by your dopamine beta hydroxylase by using vitamin C. All these cofactors, they can be tested, they are there, especially this, all of these, like this whole pathway is very important. Okay, and now if your L-dopa is, as I told you, is also converted into melanin. So if you do not have this enzyme that produces melanin, like tyrosinase, okay, you can have albinism. This is just there, sometimes they like to ask about this, like what happens, like how is vitiligo different from albinism? So you know, in vitiligo you have destruction of melanocytes. In your albinism, you have tyrosinase enzyme deficiency. Okay, now this dopamine is basically converted into norepinephrine, and this norepinephrine is converted into epinephrine. I'll try to make this thing very easy for you. First, you should remember this dopamine can directly be converted into homovinilic acid. That's why this can be detected whenever you are having high activity of this pathway. Okay, like in, you can say, uh, that thing, fuchromocytoma, where you produce a lot of epinephrine, meta epinephrines. Okay, so now you have to remember here that dopamine can directly be converted into your homomindalic acid. Okay, and this dopamine can be converted into norepinephrine. You have to remember something, that this norepinephrine can be converted into epinephrine. Okay, we will talk about this. Okay, uh, metapinephrine. Okay, so norepinephrine can be converted into metanephrine, and there is no space. Wait, you should remember that your norepi can be converted into meta norepi, and epinephrine can be converted into nor meta epinephrine. Okay, okay. The word that you need to consider here is the meta word. Okay, so whenever you convert your norepinephrine to meta norepinephrine, right, like this thing, you utilize your COMT enzyme. Okay, and same enzyme helps you with the conversion of epinephrine to your meta epinephrine, like this thing, again COMT. So COMT. Okay, the only enzyme that is unusual, or you can say can be difficult, is your norepinephrine that helps or is converted into epinephrine by your enzyme SEM. Okay, so what is happening here? Phenylalanine is converted into tyrosine, then dopa, then dopamine. Dopamine can go into homomannalic acid or into norepinephrine. This same norepinephrine can be converted into metaepinephrine by your COMT, and this norepinephrine can be converted into epinephrine by your enzyme SEM. This honestly, do you need to remember this enzyme name? Not as such, but you need to remember COMT. Okay, and then you are this epinephrine that you synthesize from your norepinephrine by utilizing this SEM enzyme. You will metabolize your epinephrine into COMT, and into metaepinephrine by using your COMT. Okay, and in nutshell, both of them are then metabolized to your vinyl mandelic acid. This is the main thing, by the enzyme monoamine oxidase. Okay, so this you have to remember, because these same drugs can be tested with your psychiatric drugs, where you have monoamine oxidase inhibitors for Parkinson or for psychiatric conditions. They can be there, they can be tested. So you must keep in mind that your norepinephrine is metabolized into meta stuff by your COMT. Epinephrine is metabolized into metaepinephrine by your COMT, and then from that point, metaepinephrine and metanorepinephrine both are metabolized into vinyl mandelic acid by using monoamine oxidase. This whole pathway is important. That's why I took some time to make it very clear. Now we will talk about the disorders itself. So you can see phenylketonuria. In this, you need to remember that if you cannot convert your phenylalanine into tyrosine, because of deficiency of this enzyme or this cofactor, you cannot synthesize tyrosine, and that's why now tyrosine becomes essential. So you need to take your tyrosine from your diet, because normally tyrosine was synthesized from your body from phenylalanine, and now it's not synthesized anymore. Okay, and you can see this. How does the child present? Because if you know, one of the, like in this pathway you also produce melanin, so you cannot produce melanin, so one of the symptom would be hypopigmented skin. Okay, and this phenylalanine, it's toxic to your body, so it can lead to intellectual disability, microcephaly, seizures. Like, these are very non-specific, but what you should remember: hypopigmented skin, intellectual disability, eczema. Okay, and these phenylalanine, excessive phenylalanine is basically converted into phenyl ketones, and these phenyl ketones, or accumulation of phenylalanine, can be like, it produces a odor that is known as musty body odor. This you have to keep in mind. They mention it in the questions or something. Nowadays, it's the disease has been decreasing. Why? Because we are having neonatal screening, in which you screen the child at the 2 to 3 days of their birth, and like, if they have this enzyme deficiency or not. Other thing that you should keep in mind, if you have BH, whenever you have deficiency, what you will do is avoid the diet that can contribute to phenylalanine, of course. You can also supplement with BH4. Okay, these are the things that you should keep in mind. And what will you do? You will give tyrosine, because I told you now tyrosine becomes essential because you are not having a functional enzyme. So you supplement with tyrosine, you give BH4, and you avoid the diet that has phenylalanine. And what kind of diet has phenylalanine? It's your sweet softeners. Okay, so your artificial sweeteners, whatever they are, aspartame and all this, you avoid that. Okay, and I would also say one more thing. Yeah, so this is your phenylalanine deficiency. It could be because of cofactor also, it could be because of the enzyme itself. With the cofactor, you need to remember that your active form of your cofactor is BH4. And this BH4 is basically, you can say, coming from your BH2. Okay, so your BH2 synthesizes your BH4 by using the enzyme dihydropterin reductase. If you Now there is a thing, if you want this cofactor, you need this enzyme. If you do not have this enzyme, you cannot make this cofactor, right? So if you have tetrahydrobiopterin deficiency, like a BH4 deficiency, you need to supplement the patient with BH4 and they can improve a bit. And another thing that you should keep in mind, that like this disorder in which your cofactor is missing, this is very you can say it's very lethal compared to just enzymatic deficiencies. Okay, so it can lead to death or something. And you have phenylalanine embryopathy. This is something else. In this, what happens is, you're like the pregnant female, she has elevated levels of phenylalanine, and they can be like these elevated levels of phenylalanine can be transmitted to your infant, and they can lead to growth restriction, microcephaly, intellectual disability, congenital heart defects. This you have to remember. Again, same things are there: intellectual disability, microcephaly. You should remember these. Okay, and yeah, so this is it. The phenylalanine is very important, I would say, for exam purposes. Sometimes like you can see that this is on your assessments too, so it's quite easy. Main symptoms you should always remember: intellectual disability, skin hypopigmentation, and eczema. Then you have maple syrup urine disease. This is very unrelated. We will just come to it in a second. We will first discuss L-captonuria, because this is the disorder in which we talk about accumulation of your homogentisic acid, right? So in this disorder, what happens is that you cannot metabolize your homogentisic acid into your fumarate so that it can go into TCA cycle, right? So what happens is you keep on accumulating your acid, and this is toxic to your body. So what kind of things you can see? You can see this homogentisic acid being accumulated in your joints, in your cartilage, so it leads to arthralgias that are debilitating. Okay, this is something that is there in the questions, and that can be the only symptom in the question, so never miss it. Like arthralgias, in which you can rule out all other diseases, you just see this debilitating arthralgias, keep alkaptonuria in your mind. Okay, the other thing is that this is like this homogentisic acid has a pigment, so that's why whenever it builds up, it leads to pigmentation in your eyes, in your, like mostly in your soft tissues, you can say. So in your eyes, here, if you can see, it's here and it's here. Okay, it can be in your ears also, and if it's in sclera, like in this picture, it's known as uchronosis. Okay, and if the patient urinates, it can turn black on the exposure to the air, because this is acid, it is oxidized and lead to discoloration of your urine too. Now you can also, so yeah, now we will discuss about maple syrup urine disease. In this, what happens is that your amino, like this disease is it is written here, but it's a disorder of your, you can say, amino acids that are not related to this stuff. Okay, it's just that you have branched amino acids. And what kind of branched amino acids? Like you have three branched amino acids: isoleucine, leucine, and valine. Okay, they cannot be metabolized, and because they are not metabolized, you develop this maple syrup urine disease, in which what happens is your urine smells like a burnt sugar. Okay, that's why the name maple syrup urine disease. That's the only thing. And the other thing is again your intellectual disability, like a neurological decline. And why does this happen? Because you cannot metabolize these branched amino acids, and due to the deficiency of which kind of enzyme? This alpha ketodehydrogenase enzyme deficiency. How do you treat it? You restrict the diet that contains isoleucine, leucine, or valine. That's the main thing. Okay. This homocystinuria is very high yield. It's extremely high yield topic. You should know about it very well. Okay. So I'll try to make it easy for you. For homocysteine, I want you to think and I want you to remember that your homocysteine is basically converted into your, this is your homocysteine, it's converted into cystathionine, and from that it is converted into cysteine. Okay, and this is converted into methionine. Okay, so if you remember your B12, it leads to this methylmalonyl CoA and all this accumulation, all this stuff. So for some reason it helps me to remember whatever starts with M, the enzyme that makes this product that starts with the word M utilizes B12. So maybe helps you also. You can remember your B12. Okay. So B12 is a cofactor for this reaction. Homocysteine can be converted either into methionine by utilizing B12. Homocysteine can be converted into cystathionine or cysteine because it's C. So you can remember it's 6. So C and 6 like quite similar. So it utilizes B6 and this utilizes B12, and it's exactly the half, like 6 is the half of the 12. So yeah, maybe it helps you to remember it. And of course this also utilizes B6. The whole pathway here with cysteine utilizes B6, and whole pathway here utilizes your B12. The common deficiency that you have here is your cystathionine synthase. Okay, cystathionine synthase. If your this enzyme is deficient, what happens is that you will convert all of your homocysteine into methionine. Okay, and that's why what you do is in the treatment you decrease the diet that has high levels of methionine. The treatment is you decrease your methionine because then this homocysteine is not accumulated and can be directed to the formation of your methionine. It helps with like what, like when I say whenever you have symptoms like homocystinuria, like it's very close to Marfan syndrome. It can be confused with your Marfan syndrome. So if someone is suffering from homocystinuria, it means we need to metabolize this into something. And if your diet is very sufficient in your methionine, you cannot help this homocysteine convert into methionine, right? So what you do is you decrease the levels of methionine in diet so that this pathway is stimulated. Okay, and we know there is no cystathionine synthase. Of course, that's why we are having this homocystinuria. You can you can also supplement B6. You can also give cysteine because it's also not produced because of enzymatic deficiency of this thing. You can also give B12 so this pathway goes on smoothly and all this stuff. Okay, this is the one that is highly tested in your exams. For others, you can make a sense out of it, but the most important one is the cystathionine synthase. Okay, for your methionine synthase, you should remember you can see homocystinuria if you have methionine synthase deficiency. Now what will happen? Your whole pathway will be directed to the formation of your cysteine and cystathionine. Okay, you will not produce your methionine. So you just what you do, you supplement with B12 and you provide or supplement with the methionine diet. That's the whole thing that you do. Okay, and after this, how it presents is very important. That homocysteine, you can see homocystinuria. You can see osteoporosis is very high yield. You can just remember it. It leads to osteoporosis. It has Marfanoid habitus. That's why it's also confused with Marfan syndrome. It can lead to your ocular changes in which you have downward and inward lens subluxation. If you remember Marfan, it's your outward and upward dislocation. Cardiovascular diseases are very common here, like thrombosis, atherosclerosis. This is very high yield. This can be tested. In Marfan syndrome, you have abnormal dilation, like aortic regurgitation and all this. That leads to, or aortic dissection that leads to the disease. But in homocystinuria, you have thrombosis and atherosclerosis. You can have kyphosis as well. You can also have intellectual disability too. Okay. Okay. And then you have uh, intellectual disability is common to both homocystinuria and Marfan syndrome. Hypopigmented skin again can be seen. and up and out. So I told you everything. This pathway is highly tested. It's like extremely tested. So at least you should keep this in mind if other things are a lot for you. Um, this is like a cystinuria. This is very different. In this, what you have is, I want you to remember whenever you hear this word cystinuria, you should remember cola amino acids. Cola amino acids are basically cysteine, ornithine, lysine, and arginine. Okay, and what is the defect here in this disorder? Your proximal convoluted tubule cells, they fail to develop they fail to develop the transporters or enzymes that helps with the absorption of these cola enzymes. Okay, so you see excretion of these amino acids, and you must have known that you can form your cysteine stones. And why do you form cysteine stones? If you have this deficiency in your transporters that help with your reabsorption from your PCT and your GI tract. So you can form stones. How do you treat it? Journal management. As for all stones, you can have alkalinization, you can have citrate, acetazolamide, penicillamine, on all this. And this is just there. I In your assessments or in practice exams, I haven't seen this much being tested, but it's always good to keep some idea that in this disorder, where is the defect? It's your proximal convoluted tubule. What is the defect? You cannot absorb your amino acids, and that's what leads to a stone formation. That's the main thing. For organic acidemias, you should remember, like, this literally means that you are accumulating your acids in your body. So all your assets that can be converted or that can participate in your gluconeogenesis, they are not metabolized. That's the main thing. All your amino acids that they can contribute to your gluconeogenesis, they are not metabolized because of enzymatic deficiencies, and they cannot contribute to your either glycolysis or your gluconeogenesis. That's the main thing. Okay, the only one thing that is very unique here, along with amino acids, you also have odd chain fatty acids. They can also accumulate and can contribute to organic acidemias, because it's just acidemias. You know, your proteins or your amino acids, they can be basic or they can be acidic. Okay, so if you have acidic protein buildup, it can also contribute to organic acidemias. If you have fatty acid buildup, it can also lead to your organic acidemias, because in the end both are acids. So what happens is, it means you cannot go into glycolysis, it means you cannot go into gluconeogenesis. So what will happen? You will have hypoglycemia, of course. So in this, the children presents with failure to thrive, hypotonia, metabolic acidosis, because now your gluconeogenesis is not there, your glycolysis is not there, and you are relying on your fat metabolism, even chain fatty acids. You rely on those, and they can contribute to your ketone formation. So you see ketoacidosis, and that's why you see high anion gap metabolic acidosis too. Okay, they can contribute to it, but after some time, when the stores are depleted, you can see hypoglycemia there. Okay, all these enzymatic disorders, Caesar's, hepatomegaly, intellectual disability, microcephaly, these are like very non-specific. You need to be. They always mention this in the question. There is always some kind of hint to tell you what kind of disorder is going on, so you can pick it. If I were to say what is very important for organic acidemias, you should always keep in mind hypoglycemia plus ketoacidosis plus hyperammonemia. We will talk about this. Okay, if you see this combination, you know you're dealing with your organic acidemias. Okay, now this organic acidemias, when they're accumulated like this, all these all amino acids and fatty acids, when they're accumulated, they inhabit your mitochondrial enzymes. And if they inhabit your mitochondrial enzymes, if you remember or if you know that your urea cycle is partly in cytoplasm and partly in your mitochondria. So if you inhabit your mitochondrial enzymes, it can lead to your inhibition of your urea cycle and hyperammonemia. So if you see a combination of hypoglycemia, ketoacidosis, and hyperammonemia, it's your organic acidemia. Okay, and why would you have this? Because you have deficiency of one or two enzyme. Okay, you can have deficiency of propionyl CoA carboxylase. This is one of your odd chain fatty acids, propionyl CoA, and this cannot be converted. So the pathway doesn't go forward, and you accumulate these all proteins. and this propionyl CoA is basically converted into methyl malonyl CoA. And if again you do not have methyl malonyl CoA mutase, you cannot proceed with the pathway and you accumulate the whole thing. Okay, you need to remember this, that propionyl CoA is 3C and this is 4C stuff. So your biotin would be there because it contributes to your carbon, as I told you yesterday. And whenever something starts with M or something with M is there, especially with methionine, methyl malonyl, the cofactor that you utilize is your B12. Okay, is your B12. This you should keep in mind. And how do you treat? You avoid the diet or you avoid the proteins or amino acids that have these amino acids like valine or chain fatty acids, methionine, isoleucine, tyrine, vomit. Okay. Most of the time, the question that shows up for this in the exam is on the diagnosis. Like you pick that what is it, propionyl CoA, is it methyl malonyl CoA mutase, what kind of enzyme is deficient, something like this is there. Okay. Now we will talk about glycogen storage diseases. Okay. Before I proceed with this, I believe you all are clear with this amino acid metabolisms, right? Someone can just say it, or if you do not have any questions, so I can proceed. Yeah. Okay. Glycogen storage disease. There is a trick in the book. What they have done is they have written two things together. This is the synthesis of glycogen, and this part is your degradation of your glycogen, right? So don't mix it, because when they have written it, they have talked about both the disorders together, right? But they are different. One is with the synthesis, other one is with the degradation. Okay. So what happen is your glucose, it comes in, and your glucose can be converted into glucose 6 phosphate, and from this glucose 6 phosphate you can convert it into glucose 1 phosphate, and from glucose 1 phosphate you convert it into UDP glucose, and this UDP glucose can be converted into glycogen. Okay, your first step, that is your glucose coming in and making your glucose 6 phosphate, and the other step is your glucose 6 phosphate converted into glucose 1 phosphate by using the enzyme UDP glucose phosphorylase. Is this very important? No, because there is no clinical disorder with it. Just you can just keep in mind that UDP is there whenever we have glycogen synthesis. Okay, then of course from your UDP glucose, you can say you pile up your monomers of your glucose, right? So what kind of enzyme would you use to form your glycogen synthase, because you combine all the glucose molecules, right? So you have glycogen synthase to help you with the synthesis of your glycogen from your glucose monomers. UDP glucose, they pile up, form glycogen by using glycogen synthase. Okay, this is a thing that you should keep in mind. Are these enzyme and this whole thing very significant? Not as such. Okay. Now what happened is your body wants to maximize the storage of your glycogen. So yeah. So I was saying that your body wants to synthesize or maximize the you can say it wants to maximize your glycogen synthesis, right? It wants to store as much as glycogen as possible. So what it does is, first it stores it in the linear form, like a horizontal form, then it stores it in the form of your branching. Okay, by using the enzyme. The enzyme name is very, you can say, obvious. You can say branching enzyme. It's just simple as that. Okay, and you have just one disorder with it. So with storage we only have one disorder with the enzyme, that is branching enzyme. If it's deficient, it can lead to glycogen storage disease, which we will just talk about in a second. Okay, so this is all about synthesis of glycogen. Now comes degradation of glycogen. So glycogen degradation, it begins with the enzyme glycogen phosphorylase. Okay, and in this glycogen phosphorylase, what happens is you break one molecule of your glucose, right, from your branching chain. First thing is this: you cleave your branching chain first, and you just separate one molecule of your glucose. Okay, until you are left with last four glucose molecules in that glycogen part. Okay, So what kind of enzyme you utilize is your glycogen phosphorylase. If you see here, you have some kind of six or something. In the end, you are left with four. So glycogen phosphorylase, it helps with your glycogen degradation by removing one molecule of glucose until you are left with only last four glucose molecules. Okay. And when this happens, what happen is that then you have another enzyme that comes in and separates these one molecules. Okay, this is your debranching enzyme. Okay, this is your debranching enzyme. Very simple name because it is debranching. It's simply you are cutting off this branch, so debranching enzyme. Okay, and after this, then the last molecule is left again. Why is it like this? I don't know, but it's like this. Okay, so all the molecules on the branching point were removed by glycogen phosphorylase until the last four. Then you had branching enzyme that removed all the other components of your glucose until you are left with the last one. Okay, and your last one is then removed by your other deep branching enzyme, which is your 1,6 glucosidase, and this you have to keep in mind. Okay, and for this one, the enzyme name is 4 alpha d gluconeotransferase. I'll try to make it easy for you so you remember the enzyme names, but for now you can just bear with me. Okay, and in this way you are just left with a linear or horizontal chain. Then again your glycogen phosphorylase comes in and it cleaves on and keeps on cleaving. So this is the whole thing that happens, and after this one molecule of glucose is, you can say, free to go, if it is of course converted back into this glucose thing, right? It goes into glucose 1 phosphate and then into glucose, and now there's a time to exit from the cell, from the liver cell, and go into the periphery. And if you guys remember, I told you that your enzyme glucose 6 phosphatase helps with or facilitates the conversion of the glucose 6 phosphate into glucose and helps it exit. Okay, so if you have deficiency here, you can have again a glycogen storage disease, which we will just talk about in a second. Okay, this whole pathway you should keep in mind, and it's quite easy also. One more thing, that your glycogen is stored inside the cell, of course, your liver cells or all this stuff, but some glycogen is also stored in your lysosomes. Okay, and for lysosomes, for the degradation of your like whatever glycogen is inside the lysosome. What is lysosome? It's basically, this is your whole cell, this is nucleus, and this is mitochondria, you can say. Okay, here you have lysosome, and this lysosome also stores some form of your glycogen, and this glycogen is basically again metabolized to glucose, right, by another enzyme, and this is your alpha 1 4 glucosidase. This you have to remember. Okay, in your lysosome you have alpha 1 4 glucosidase. This is also known as acid amylase. Okay, so these are the disorders which we will just touch in a second. Okay, and so only one disorder with the storage, all other disorders are with the degradation. This is something that you should keep in mind. Okay, and now if you see, this is the disorder that is with your synthesis. Okay, this is with your synthesis, the Anderson disease. So first and the most common, frequently tested, is your von Gerke's disease. In this disease, what happened is your glucose is trapped here, and like your glucose 6 phosphate cannot be converted into glucose and exit the cell. So your glucose is basically trapped inside the cell because of the deficiency of glucose 6 phosphate. Okay, so what happens is you see severe fasting hypoglycemia because your all glycogen, whatever is there, it cannot be utilized, right, and it cannot free up the glucose. So you see severe fasting hypoglycemia, your glycogen, whatever your glycogen you have, either it stays like this or it is accumulated simply because it knows that in the end I have nowhere to go or nowhere to exit. So you deposit or store or accumulate your glycogen inside the liver and the kidney cells. As I told you, your kidneys are also the cells that can help with your gluconeogenesis, and of course or your glycogenolysis, both things. Okay, so of course you should keep in mind that in this disorder, if you cannot free up your glucose, of course you cannot contribute to your fasting glucose levels. Okay, so glycogen is accumulated in liver, kidneys, and of course then the cells start relying on your anaerobic glycolysis, and that's why you accumulate your lactate too. Your triglycerides and uric acid increase because what you do is you start synthesizing or start metabolizing your fat, and this, you can say, increases the level of your free triglycerides in your bloodstream. Okay, so your triglycerides increase, your lactate is increased because you are relying on anaerobic glycolysis, and your uric acid is also increased because your body starts degrading your proteins to rely for the energy, right? So you can see gout. This whole presentation is very, very high yield, very, very important. Hepatomegaly, renomegaly, as I just told you, liver does not regulate blood glucose because your enzyme that is deficient. So how can liver contribute to the glucose, blood glucose level? So it cannot contribute to it. How do you treat it? You avoid fasting. So you supplement frequently yourself with glucose, cornstarch, and blah blah blah. And your gluconeogenesis, of course, is inhibited because in the end, the and exit pathway is the same. This can also, even if you have gluconeogenesis going on, it cannot contribute to your blood glucose, and same for glycogenolysis. So I believe this thing is very, very clear to you guys. Okay, same goes for fructose and galactose, because this point I need to go back. It's like this. Let me show you something. So if you see here, this is your fructose. This fructose is going into DHAP, glyceraldehyde, and then into the glucose. So if you do not have enzyme here that can help with the conversion of glucose 6-phosphate into glucose, of course, it means even giving fructose is also dangerous. And same goes for your galactose. Okay, even your galactose that is contributing here cannot go and contribute to glucose. So that's why in this disorder you also avoid your fructose and your galactose. Okay, and now I will talk about this whole thing is your von Gerke's disease, very high yield to keep in mind. Okay, then you have Pompey's disease. In this Pompey's disease, what happens is that you have lysosomal acid that I just told you. In your lysosome, you also store some form of glycogen. If you have deficiency of this enzyme, that leads to your Pompey's disease. You can remember it's Pompey, so it's pumps, so it's related to heart only. So it leads to cardiomyopathy, and if you cannot pump, you cannot supply the blood. You can see hypotonia, exercise intolerance, which is very obvious. Again, your heart cannot pump very well. Enlarged tongue, it's very unique. You have to just remember again why, because of the deposition of your glycogen in these tissues. It can lead to early death because of the problems in your heart. Okay, lysosomal acid, alpha 1 4 glycosidase, acid maltase. How can you remember this? You can remember heart has four chambers. So whatever enzyme that has, like you have one heart but you have four chambers, so alpha 1 4. Okay, and it's in lysosome, and you know lysosomes are very, you can say they are very very destructive. So they are acidic, you can think of it in this way. So acid maltase, lysosome. And we know with lysosome, we what kind of disorder we have, Pompey's disease, and that's why we remember that it's with the heart. So you have one heart, four chambers, alpha 1 4 glucosidase deficiency. This is it for Pompey's disease. Okay, then you have Cory's disease. In this Cory's disease, what happened is that you have problem with debranching enzyme. Okay, either this or either this, either this or either this. Okay, you have problem with your debranching enzymes. And if you cannot, um like if you see at this whole thing, the only problem you have is with the D branch stuff, right? It means initial glucose molecules can be utilized for the glucose or maintaining the blood glucose level, right? It's only that if they accumulate, these branched glycogen particles, if they accumulate, they can lead to some kind of disorder, but you will not see hypoglycemia as such, right? This logically makes sense, correct? So what happened is it's similar to von Gerke's disease, but milder symptoms, no lactate elevation, because your whatever glycogen you stored, it can be metabolized into glucose until you reach the last four molecules of your glucose, right? Then you have the problem. So that's why you do not need to rely only on the anaerobic glycolysis. That's why it's a milder disease. It can again lead to accumulation, and that's why if it's accumulated, it can lead to cardiomyopathy. This is also known as limit dextran disease. What do they mean by limit dextran disease? It literally means that these chains, if you see, they are limited, like four molecules only. So that's why they are known as limit dextrin, like limited carbohydrates. Dextrin is like dextrose, which is also your carbohydrate, right? So these are accumulated in your cytosol. It can lead to hepatomegaly, cirrhosis, hepatic adenomas. So in Cury's disease, you have heart problem, liver problem. We understand this. Why? Because of your accumulation of your glycogen particles that needed this debranching enzyme. Gluconeogenesis is intact. Why? Because you have glucose 6 phosphatase that can help with maintaining your blood glucose level. Okay. Then you have Anderson disease. And in this Anderson disease, I told you the problem you have is with the branching enzyme. So we will talk about this in a second. First, we discuss about myocardial disease. Okay. In your myocardial disease, what the problem is that you remember your glycogen phosphorylase. Let me show you this one. Your this enzyme, glycogen phosphorylase, the first that initiates the breakdown of this whole thing. The muscle has its personal, you can say, glycogen phosphorylase, and that's why it's known as myophosphorylase. This means I cannot even initiate glycogen degradation in the muscles if I have deficiency of myophosphorylase, which is your glycogen phosphorylase, right? So this means my muscles, whenever they undergo intense exercise and your glucose is deficient in your body, or your blood is becoming deficient in glucose, my muscles, they cannot produce for glucose, right? Because they cannot convert your glycogen into glucose, correct? So what happen is increased accumulation of glycogen into the muscle because you're not degrading them. It can lead to muscle cramps. This makes sense. Myoglobinuria, again, when you have degradation, because when you do the intense exercising and you cannot contribute to your glucose or energy, you break down your muscle. Okay, so it contributes to your myoglobinuria, red urine, especially with strenuous exercise. Of course, whenever you have, this is something very general to all disorders. Whenever you have cell lysis, okay, especially muscle lysis, you will always see myoglobinuria. You will always see hyperkalemia, because your cells are bags of potassium, and because of this hyperkalemia you can see arrhythmias. Okay, and because of this hyperkalemia you can see electrolyte imbalances, okay, or abnormalities. So these are also there. Few points that are very important for exam purposes is that you should remember that second wind phenomena. In this, what happens is that the first time you did the exercise, right, an intense exercise, you did not have sufficient glucose to provide to the muscle, because you are deficient in this enzyme, right? So whatever glucose was provided by your blood circulation, that was picked up by the muscle and utilized, right? So in when you do the first exercise, your body does not know that thing, right? And your muscles are also stiff, right? If you remember, after you stop exercising, your body knows that okay, I need to send blood to my muscles because they are stiffening, or there's a pain that I'm feeling and I need to increase my blood flow. So when second time you exercise, before that your body compensated by increasing the blood flow, and that brought you the glucose too. So first time when you exercised, suppose you had 50 units of glucose to your muscles, suppose, okay, then you stop because you had pain and all this stuff going on. The second time your blood flow will increase and it will bring on 200 units of your glucose. Now muscle has not to rely on glycogen storage, it has to rely on this blood glucose easily, it can rely on this blood glucose easily. Okay, so this is something second phenomena. So you see that like your second time increases your muscle blood flow, it helps you with the disease. Two findings are there, because you cannot degrade your glycogen and they cannot go and convert into glucose. It means if your glycogen cannot be converted into glucose and this cannot be converted into pyruvate for the energy, this means you never formed pyruvate, and this means you never formed lactate, right? So this comes up on shows up on the exam. Either they can write this thing, flat venous lactate curve, or they can give you a curve in which you see that your lactate levels are like this, like fully straight, right? So if you see this thing happening, you know it's your myocardial disease. Because why? We could not form lactate because we did not free up the glucose from the glycogen, because you had deficiency of this enzyme glycogen myophosphorylase. Okay. The other thing is that your muscles, then what they do is they start again degrading your proteins because they are not getting energy from your glycogen, so your ammonia level increases. So that's why this is all about mcardle's disease. And one more point, blood glucose are unaffected because why would they be affected? It's only the muscle problem, not a generalized blood problem, like not a peripheral problem. Okay. Then you have Anderson disease, less tested, but it's there, so you should keep in mind. It mostly, you can say, it leads to your cardiomyopathy. It can lead to your neuromuscular problems. It can lead to hepatosplenomegaly because in this branching enzyme, it means what you do is you just accumulate your glycogen without forming branches, right? But again, you are what you're doing, what you're again accumulating it, right? That's why, although it's a synthesis disease, but it's counted as a glycogen storage disease. Why? Because you are storing this glycogen that is not branched, but again, it's a storage disease. So hepatosplenomegaly, failure to thrive, and you see cirrhosis, you see weakness, hypotonia, cardiomyopathy, childhood death is also there, and you also have some neuromuscular symptoms, and hypoglycemia can be there if the disease is very advanced and late. That's the whole thing that you have to remember. Okay, so I believe we are very clear on these glycogen storage diseases. If someone has any question, please they can ask.
Doctor, could you please
Uh, can
uh,
you speak
yeah,
loudly? Because
can you can you hear me?
yes, now I can hear you.
Yeah, could you please explain the flat?
What thing should I repeat? Your voice is breaking up.
Okay, I'm very good. So flat venous.
Can you write it down in the messages so I
Sure.
can see? Maybe. Okay, flat venous curve thing. So for this, you have to remember that normally what happens is that you are in your exercising muscle. Okay, in your exercising muscle, what happens is your glycolysis is there, right? You would require energy, that's why your glycolysis will go on. And we know that in glycolysis what happens is your pyruvate is, it can go into tc cycle, it can go into lactate too, right? But generally in normal people, the pyruvate, uh, when the muscle is exercising, pyruvate goes into the tc cycle and provides for the energy. But because there is intense, you can say, pressure or work on the muscle, it also, some of your pyruvate also goes into the lactate, right? And this lactate also provides energy because in reaction you form atp and stuff, so it also provides you with the energy. Okay. So in normal person, in normal exercising muscle, you will have some lactate levels. Okay, in blood you will have some lactate levels. But in person with myocardial disease, the problem is they cannot degrade their glycogen. If they cannot degrade their glycogen, it means they cannot use their glucose because glycogen is a polymer of glucose. Simple as that, right? And if they cannot utilize the glucose, it means they cannot undergo glycolysis, which literally means you cannot make pyruvate. If you did not even make pyruvate, how can you go into the lactate pathway? So that's why your lactate curve in your myocardial disease is flat. Okay, that's the whole point. I believe this is very clear to you now.
Thank you, doctor.
Okay. Yeah, no worries. So it's been 1 hour. We will stop here, and I believe this whole thing was very clear to you guys. Okay, so I'll see you tomorrow then. Bye, everyone.